Okay, welcome everybody. We have a lot of people pouring in here. It is 5 o'clock Western time, 7 o'clock Central time, and we're getting ready for our webinar with Dr. Kassenbrock. I see everybody coming in quite rapidly. We are going to just stall here for just a minute, for probably maybe 3 minutes after the hour we'll start while everybody is coming in. So if you all can just sit tight. I'll be back in just 2 minutes if you can just sit tight. Oh, Brooke is in here. We can't hear you, Brooke. Ken is in here. Dr. Kassenbrock.
Excited.
Okay. Brooke, are you going to come in with volume in a sec?
Can you hear me?
I can. I was just telling everybody we're going to start in about a minute. We have a lot of people pouring in. We have hundreds of people coming into this right now. So we thought we would give everybody a few minutes. They're still coming in at a pretty good pace.
I'm going to check how many are registered. I'm still sending links to people that aren't seeing them for some reason,
okay,
which happens, but I'll just keep doing that.
Okay, good.
And unfortunately, in the article, he used a pseudonym for Maria Sabina, but people found out who it was. And Maria Sabina was later besieged by people coming to look and partake of the mushrooms, and including apparently people, big famous musicians, John Lennon, Mick Jagger, Bob Dylan, Jim Morrison, Peter Town, and hundreds of others. So she has become iconic after her passing. So you can see all these images. But at the time, it was sort of like no good deed goes unpunished kind of situation. The people's coming into her village really disrupted life for everyone. The police thought that she was dealing in drugs and made it difficult. At one point, her other people in the village burned down her house because she was just, so it's a bit sad, but after she's passed, she's very, very well known. So back to the story, here's the mycologist, Royer Eim, who was brought down to try and figure out what these mushrooms were. And a couple had been previously described, but the psychoactive nature was not known. And then a number of the species he described from these studies. And he was able to cultivate some of these species back in Paris. And then they approached Albert Hofmann, who was the guy to go to for hallucinogenic compounds. He had a few years earlier discovered LSD, making some derivatives from extracts of a different fungus, of ergot. He had synthesized LSD and discovered its psychoactive properties. So he was the world expert in this kind of subject. And so they brought him mushrooms and said, can you figure out what's in here? And he did. I was fortunate enough to hear him speak many years ago about this, to give a talk. He lived to be well over 100, 102, I think. And it was fascinating, the talk he gave describing the purification. You know, when you are trying to purify things, you do some kind of chromatography and separate substances, and you get various peaks, but you have to assay them. You have to know where is the hallucinogenic material, the hallucinogenic activity, where is that going with regard to these different peaks of substances that have been separated. And they didn't have a good animal assay. You couldn't tell if a mouse or a rat or a bunny was hallucinating. So they ended up giving little aliquots of the fractions to volunteers in the lab. Okay, you take some of number 2, you take some of fraction 4, you take some of fraction 6, and it was fascinating. But they were successful in identifying the molecules involved, and later Sandoz Pharmaceuticals, which was Hoffman's employer, started producing this commercially and making it available to researchers and physicians. It was marketed as Psilocybin for a few years in the 60s. So here are the compounds involved at the bottom of your screen, and there are a number of species in the genus Psilocybe and several other genera, Copelandia, Canocybe, Gymnopilus, Inocybe, Pineolus, Pluteus, that contain these compounds, psilocybin and related alkaloids, psilocin, baeocystin, norbaeocystin. These compounds produce hallucinations by interfering with the neurotransmitter serotonin, and in particular, psilocin is an agonist at a particular serotonin receptor called the 5-HT2A receptor. And psilocybin, let's see if I can get my laser pointer to. Okay, here we go. That's, hopefully you can see that. So psilocybin and psilocin differ just by this phosphate group. It turns out in the brain, the compound that crosses the blood-brain barrier and has its effects is psilocin, but it's not very stable chemically. So if you want to make something into a pill, psilocybin is a much more stable molecule. And in the body, once you ingest this, the phosphate comes off readily. So psilocybin is essentially a prodrug for psilocin. They have the same activity. Okay, and so the effects, as you may know, begin within 20 minutes to an hour and typically last 4 to 6 hours, and include things like heart rate, increased blood pressure, feelings of stimulation, exhilaration, anxiety, nausea, visual hallucinations, often of detailed moving patterns, synesthesia or mixed perception, such as hearing colors or seeing sounds, altered perception of time. And psychological effects depend greatly on set and setting, which were concepts that were first published by psychologist Timothy Leary, who we'll say a bit more about in a minute. Set is sort of your expectations. What do you expect is going to happen? What's your understanding of how this compound or these mushrooms may affect you? And so if you eat these mushrooms unexpectedly, or if you're anxious or worried, the experience may be perceived much more negatively than if conversely you're expecting a positive or beneficial experience, which makes that more likely to occur, but doesn't, of course, guarantee it. And then setting is your physical setting, both in terms of the environment, your surroundings, but also in terms of people around you and how supportive you perceive them to be versus hostile or unaware. So there's a wide variety of effects that have been reported, both positive and negative. Euphoria, in terms of positive, there's feelings of insight and euphoria. People describe new understandings of truth and reality, feelings of connectedness to the universe. Negative, people can be anxious, confused, agitated, or panicked, terror. And often it's a mix, and it can be dose related with the scarier things emerging often at higher doses. I wanted to say just a couple of words about Timothy Leary. He was a lecturer in clinical psychology at Harvard from 1959 to 1963, who advocated for the study and use of hallucinogens, but honestly, he advocated in a rather irresponsible way that I'll mention. So he was very interested in these compounds, both psilocybin, the magic mushrooms, and LSD. later. I learned more about psychology in the 5 hours after taking these mushrooms than in the previous 15 years of studying and doing research in psychology. That's one of his quotes. Probably his more famous quote is turn on, tune in, drop out. He sort of became an evangelist, a proselytizer, feeling that these compounds were good for everybody, for everything, and he ended up losing his job at. So he was involved with a project called the Harvard Psilocybin Project, where they were studying effects. They would administer these the psilocybin pills to graduate students who had volunteered, but he ended up being fired from his job for giving psilocybin to undergraduates who are not part of the study, and for not teaching some of his classes. And he had just a crazy life that you can't even believe when you read biographies. At one point, President Richard Nixon called Leary the most dangerous man in America. And it was really a backlash to his kind of approach. Hallucinogens are great for everyone, for everything, and a number of other factors that led President Nixon to declare drug abuse to be the public enemy #1 and began the war on drugs, and really criminalized this whole area and stigmatized research as well. And it actually became taboo to even talk about the beneficial studies that had been done earlier with both LSD and psilocybin in some psychological conditions, that people just said, you're not a serious researcher if you're going to talk about this. It was a kind of self-censorship that lasted decades and is unfortunate. So currently, possession or cultivation of mushrooms containing psilocybin or psilocin are illegal under federal and state law, although 2 states have changed those laws, as we'll talk about. Psilocybin and psilocin are Schedule 1 under the 1971 Convention, United Nations. And as you know, Schedule 1 are drugs that are not supposed to be used for anything. No recognized medical uses, high potential for abuse. Interestingly, there's a kind of a loophole in that although possession and sales of mushrooms is illegal in the United States and many other countries, sale and possession of psilocybin spores is legal in most states because the spores don't contain psilocybin. And there's a brisk business in selling spores online. So, of course, if you germinate those spores, that is illegal, and it's considered drug manufacturing and commands worse legal effects than mere possession in many cases. So if you here's a slide I made a few years ago, just some of the images that you find if you just Google spores, and you can see there's a brisk business in selling spores. So Psilocybe cubensis is probably the most well-known hallucinogenic mushrooms. It was first described as Stropharia cubensis from Cuba, but grows widely around the world in tropical and subtropical areas as a mushroom on herbivore dung. And it's found in the US pretty commonly in the Gulf states and Florida. And it's the most common magic mushroom because it's really easy to cultivate. It's large and it has a rapid life cycle, and it likes the same temperatures that people do. So since it's subtropical, it does well indoors in people's houses. Some of the other mushrooms I'll describe like colder temperatures and are more difficult to cultivate. So cyanescens is another prominent mushroom, Psilocybe cyanescens. It likes colder temperatures. It's common on the west coast of North America. I used to see quite a lot of it in Golden Gate Park and landscaped areas on wood chips. and you can cultivate it outside. And the only other mushroom that I'll mention tonight, which is one of the well-known ones, is Psilocybin semi-lanceata, or liberty caps. This has yet a third habitat. So we've got dung mushrooms and wood chips. These grow in fields or pastures, but not on herbivore dung. And they're called liberty caps because of a resemblance to something called a liberty cap from the Roman Empire. So these are prominently collected in the wild, both in the United States and in Europe. So they're widespread. Okay, so psychologists and many medical professionals felt these agents had promise in psychiatric settings and certain medical settings, and we'll go into that, the current research. But as I mentioned, things really shut down following criminalization, and it became taboo to even talk about the previous studies. So lots of people went through medical school and psychiatric residencies and psychology residencies, never even knowing, in later years, never even knowing that there was a history of interesting, potentially beneficial uses of some of these agents that then stopped. But so it's actually taken decades for us to come around and start saying, maybe there was something there that we shouldn't just totally dismiss. And really, this work started from a guy, Rick Strassman, a psychiatrist at the University of New Mexico, who was the first person in decades to get the approval needed to study these kinds of substances. And he picked a different compound. He picked DMT, and the reason he chose DMT was because it had a much lower profile. People didn't really hear of it very much. It's an endogenous compound in the human body, though at very low levels. It has a very short mechanism of action. It's very similar to psilocybin. Basically, psilocybin has this phosphate group here, and DMT doesn't. So, but they have very similar actions, but they're handled by the body differently. So DMT actually isn't orally active because it's completely metabolized by your liver. So it has to be, his studies, Dr. Strassman's studies, were done with intravenous injections. Also, people can smoke DMT to bypass the liver metabolism. And we can mention more about that later. But basically, the idea was that this work, where he was able to test these substances in people and measure reactions, opened the door for a new wave of human subject research with hallucinogenic drugs. And he was very helpful in trying to show other researchers the kinds of steps that he had to go through to get approval from DEA and FDA to do these human studies. So he said, okay, this is what I did. Here's how to try and go about it. And now really psilocybin has emerged as the most promising candidate because it's orally active and it has an intermediate duration. So it rather than 30 minutes, that really brief duration, it lasts for a few hours, 4 to 6. LSD and mescaline are also orally active, but they last for much, much longer. And honestly, it's too long for easy administration in a clinic. So with this kind of time course, you can bring someone into a clinic, talk to them about what's going to go on, administer an agent, and have the effects completely subside, talk to them on the other side, and let them out the door safely without any problems. And it's been known for many years that there's very low toxicity to psilocybin. And of course, we have the history of human use for centuries, actually more like millennia, but well documented for many centuries. So we're finally getting back to psilocybin studies, including human studies, and really interesting data is coming out in therapeutic uses, a number of different things, trying to just understand the effects in normal individuals, How does it actually work? There's a lot of activity studies in human brain using various brain scanning techniques, positron emission tomography, functional magnetic resonance imaging, some of these other techniques that we don't have time to go into the details of. So I just wanted to I show this slide showing you citations on the database PubMed, which is a portal for describing the biomedical literature. And here we can see a graph of the number of scientific papers that were published that contained the word psilocybin throughout history. In 1958 is when psilocybin was first synthesized. There was an early wave of interest in it, then it subsided. And lately, in the past few years, it's been incredible, the new interest and the new research that's going on. So if you're actually going to do experiments in people, the gold standard is randomized placebo-controlled double-blind study where volunteers are randomly assigned to receive either the drug or an inactive placebo. And neither the researchers nor the patients know who received what until the end. That's the double-blind nature of it. But it doesn't actually work very well, as you might imagine, for these hallucinogenic drugs, because you can tell when you've gotten one. Okay, so the patients who actually receive an active agent immediately know that they've gotten an active agent. On the other hand, if you've never had a hallucinogenic drug, you might not know, and if you're easily suggestible, you might imagine that you're getting an effect. But the people who do get the drug definitely know they've had the effect. To try and get around the fact that people who don't receive the drug know that, in some cases, people use what's called an active placebo. So some of the things that people have used are Ritalin, which is a stimulant, niacin, which is a B vitamin that gives you a flush. You can feel it after you take a big dose of niacin. Benadryl has been used, which is an antihistamine that makes you a little bit sleepy. The idea is you've received something, and if you don't know what to expect from psilocybin, then they can attribute your reactions to just an effect of the drug versus your expectations of what you think will happen. Okay, so this is the first study that had human psilocybin administration in many decades, or a number of decades. This came out in 2006 from Roland Griffiths at Johns Hopkins. And here they were interested not in the medical uses, but just in the effects in people, and in particular, looking at the religious aspect or the spiritual or mystical aspect that so many people had described, and that these cultures had used these mushrooms for centuries, if not millennia. So while this was the first study in the United States, it's worth noting that honestly, a similar study under supervision of Timothy Leary was done many decades before by Walter Pahnke, again trying to look at the religious or spiritual nature of these effects. So I'm going to go to a follow-up study a little over a year later. This is the same group, and they went back to these patients. And I'll just read you a bit of the abstract. Psilocybin has been used for centuries for religious purposes. However, little is known scientifically about its long-term effects. We reported the effects of a double-blind study evaluating psychological effects of a high psilocybin dose. This report is the 14-month follow-up. Participants were 36 hallucinogen-naive adults So they had never used these agents before, reporting regular participation in religious or spiritual activities. And they received either a high dose of psilocybin, 30 milligrams, or methylphenidate, Ritalin, and they didn't know which was which. Okay, and the researchers administering them didn't know which was which. That's the double-blind nature. During the sessions, volunteers were encouraged to close their eyes and direct their attention inward. At 14-month follow-up, 58% and 67% respectively of volunteers rated the psilocybin occasioned experience as being among the 5 most personally meaningful and among the 5 most spiritually significant experiences of their lives. 64% said the experience increased well-being or life satisfaction. So this made a big splash. People said, wow, this compound has a very large effect in people that lasts a long time. So the way these trials are done at Hopkins, volunteers wear eye shades and headphones and listen to music. Honestly, the music is a big part of the therapy, and it's understudied. There's a particular curated playlist that's used in these studies, and it works well for some people and less well for others from what I've heard. Trained therapists are always at hand for the whole time, so that people feel totally supported, and if anything medical happens, they're able to deal with any issues that may come up. So there's just a very large number of things going on, as we'll get to, including cancer-associated, so therapeutic uses, besides just trying to figure out what these agents do. Cancer-associated anxiety and depression, major depressive disorder and treatment-resistant depression, drug dependencies, obsessive compulsive disorder, post-traumatic stress disorder. There's a whole set of things that people are showing promise in initial studies. So it's a very exciting time in research. I want to say just a word about depression, because depression is a big deal. It's very common. It's multiple % of people in the United States at any one time. And major depression is a potentially lethal illness. It's not just feeling a little bit sad. People feel so terrible they will end their lives rather than continue. So this is a huge area that needs addressing, and we'll go through some studies in moments that show there's great potential here. I should mention that even though these studies are now allowed by federal agencies, they're not funded by federal agencies. NIH doesn't fund any of these things. The funding all has to be arranged privately so far. Okay, so here's a study from Charles Grobe at UCLA that came out a number of years ago, 2011. And this was a pilot study in patients with advanced stage cancer who were basically terrified of dying, as you would be, or really depressed that their lives were over. And they arranged a study to administer psilocybin and see if that improved their outlook. And you can find testimonies from people who've been in this kind of treatment, and it's amazing that many of these people just come to peace with things, and it totally changes their lives. So other groups quickly followed this and conducted similar studies. We don't have time to go into all the details. Stephen Ross at NYU, and another study from Roland Griffiths at Johns Hopkins. So substantial and sustained decreases in depression and anxiety. So months out after a single or a couple of administrations, people had this total change in perspective. So in this case, about 80% of participants continuing to show clinically significant decreases in depressed mood or mood and anxiety at 6 months follow-up. Okay. Here's a study out of London, Robin Carhart Harris and David Nutt, the main researchers involved here. And this is a study where they looked at treatment-resistant depression. So again, these are people who've tried other therapies and those therapies haven't been effective. So now we're asking, can psilocybin make a difference? And this particular one was an open label trial, so it wasn't double blinded. So the researchers and the patients knew who was getting what. So this kind of study doesn't make as good medical evidence, but it was such a strong effect that they said it warrants further research and double blind trials. And that research was done, and we'll get to some of that. But then people have used this in all kinds of situations where we don't have very good therapies. So Michael Bogenschutz, alcohol dependence, and this was a small study, but people drank less. We'll see a follow-up for this in a minute. Tobacco addiction. So here's an early study and a follow-up. Psilocybin facilitated smoking cessation. So here's 15 participants. They followed them a year later. At 12 months, 10 of the participants had stopped smoking. That level of effect you don't see with other therapies. And this is just a couple of doses, 2 doses that were administered. And it has effects a year out. Okay, so these kinds of effects were noticed in the field, and in particular for treatment-resistant depression, when you don't have other therapies, the FDA was very interested in these early studies where they could potentially see effects. So if you don't have anything, you want to test something that looks promising. So the FDA granted breakthrough therapy status for psilocybin in 2018. That doesn't approve, it's not FDA approval, but it's a status that's meant to facilitate the passage through FDA's processes and move things along more rapidly. And it's granted to a particular agency that applies. And in this case, the agency was Compass Pathways, which is a small new pharmaceutical company that was set up just for this purpose, for using psilocybin as a therapy for treatment-resistant depression. And their model was a pharmaceutical model where you have a for-profit company who can raise capital and the money required to run large-scale studies to see if these drugs, which early studies on small numbers of people have shown promise, you have to get into much larger numbers of people before anything could possibly be FDA approved. So this was a way to do that. And it's become a little controversial for some people because as part of that sort of standard pharmaceutical model, they applied for and actually received a patent on psilocybin. And they didn't invent psilocybin. It's been around for decades. They make a synthetic version of it. They claim their synthetic version is different than other people's. Honestly, it's not. The patent has been disputed, but the dispute was dismissed. So in theory, this company could then charge licensing fees to other people using psilocybin. So it's become a little controversial, but they have begun these large scale studies, and I'll have some data in a minute from another study. So we're starting to get data back from this. So it is useful despite its controversy. Here's another. They just did this a year before, but a year later, the FDA granted breakthrough therapy status for psilocybin for the bigger category of all comers with major depression. So people who've never been treated with anything else, would this be a good therapy? You don't have to fail other therapies first. How does it compare to the therapies we're currently giving? That was what this study is looking at. And this therapy status was granted to a nonprofit called USONA Institute, which was set up just for this purpose, to provide psilocybin for studies and to try and do it in a non-commercial fashion. And we don't have data yet published back from them. Here are some of these studies. Here is something that came out in Journal of the American Medical Association Psychiatry, Effects of Psilocybin-Assisted Therapy on Major Depressive Disorders, random clinical trial. Here, the way they randomized it was you were either treated early or treated late. So you were given a compound, but early on it was inactive, or later it was active, and you didn't know which was which. A small group, 13 patients in the immediate group, 11 in the delayed group. Here's a scale that's measuring some kind of it's a questionnaire response to how depressed people are. There's lots and lots of questionnaires in these studies, various kinds of instruments that psychologists and psychiatrists have devised to figure out how people are feeling and behaving. So in this particular score, they could see a really significant effect in the people who had gotten psilocybin. And this is the early group. These people hadn't received it yet. Later, when these people received it, they also saw an effect. So they suggest findings with psilocybin therapy is efficacious in treating major depressive disorder, extending the findings of previous studies of this intervention in patients with cancer and depression, and of a non-randomized study in patients with treatment-resistant depression. So this came out in 2021. Here's another study that came out. This is Robin Carhart Harris and David Nutt in England. Again, a small study. This is comparing people with major depression to two different therapies. So the standard therapy is an antidepressant, in this case, Lexapro, escitalopram, a serotonin selective reuptake inhibitor. So some people were randomized to receive the standard therapy. Other people were randomized to just get a couple doses of psilocybin. And basically 2 doses of psilocybin worked as well as taking Lexapro every day for weeks and weeks. Just 2 single doses. And in fact, the data suggested that if anything, it worked better than standard therapy. Okay, so in this lower graph, psilocybin showed a stronger effect in treating people's depression. Here, there's some overlap in the error bars, and so they said it wasn't statistically significant, but it worked as well. So it's as well or better as standard therapy in this study. Yes, what else? Okay, move on. Here's another study. This is a follow-up, Bogenschutz's earlier study in patients with alcohol use disorder. So 95 patients were administered either half of them psilocybin or diphenhydramine, which is Benadryl, and people who got psilocybin drank less months later. So it had a strong effect. This is a very recent trial, 2022, just this year. And then here's data from Compass Pathfinder that just came out. Single dose psilocybin for treatment-resistant major depression. And here they looked at hundreds of people, 233 people, 10 countries, 22 sites, and they split people into 3 groups. You either received basically a control dose, 1 milligram. So everybody was told you will receive psilocybin, but you didn't know how much. And the control is not a perceptible amount. A milligram you can't feel. Here's an intermediate dose, 10 milligrams, and 25 is considered a high dose. And they found that while there was not much difference between the control dose and the intermediate, there was a significant difference at the higher dose, and they had a 37% response rate. So remember, these are people who have failed other therapies, who standard therapy has not worked for, and now more than a third of them are being helped by a single dose of psilocybin. So this is really promising. It's not everybody. It didn't cure everybody, but it's promising. Okay, so there are all kinds of studies out there. If you don't know about this site and you're interested in clinical trials, you should learn it. Clinicaltrials.gov is a place where clinical trials all over the world involving anything you can think of, cancer, various other diseases, and you can just put terms that you might be interested in into the search engines and see what comes up. Every time I go to this site and enter psilocybin, I get more numbers back of studies. So there's well over 100 clinical studies going on now, 128. Some of these studies are just beginning. Some of them haven't recruited yet. Some of them are finished. But if you want to get more information on what's going on, have a look at clinicaltrials.gov. I just put this up to show you over 100 studies are out there. So why does it work? Why is it being tested for so many things? Does it work for anything? Everything? Is it going to work for everybody? Well, I just showed you data that it doesn't work for everybody. Okay, we got a 37% response in that last study for treatment-resistant depression, but that's good. But it's not everybody. Actually, a lot of researchers, a lot of clinicians now are worried that there's going to be such overhyping of psilocybin that everyone is going to expect it to be effective for everyone all the time for everything. And that can't possibly be the case, right? There will be people it doesn't help. We already know that. And since we're talking about major depression, for example, there will be people who are desperate, feel this is their last hope, and it doesn't help. There will be people who end their lives. And then there will be media stories saying, oh gosh, this person killed themselves after taking psilocybin. So there's going to be a backlash. Anyway, people are very worried right now, the clinicians, because there's such promise that there's going to be a phase of it being overhyped, and then the media will start to see bad effects, and then they'll overhype the bad effects, and we'll have this sort of crazy cycle of too much of things going on. So you don't want the promise to be lost in media hype. That's the worry. But how can this possibly be the case that it's useful for so many things? For example, people are trying it now on eating disorders, on obsessive compulsive disorder, on post-traumatic stress disorder, on all kinds of things. How can one drug show promise for all these things? And why should just one or two or a few doses have such long-term effects, 6 months, many months, a year later? How can that possibly work? Short answer is, we don't know, but people have some thoughts. So if you plunk people into a MRI machine and look at their brains, look at blood flow, and you, by that you infer neuronal activity. If you just put somebody in a scanner and don't tell them to do anything, just say lie there, then the regions of the brain that are active are called the default mode network. I don't know that it's that much of a network, honestly, but it's the things that are active when you're not doing anything. You may be daydreaming or thinking about stuff, but you're not actively pursuing a task. When you give somebody psilocybin, those change. You don't see the same things light up, and you see increased brain entropy. These are transient changes. But what some people think is that a lot of mental disorders and conditions involve people getting stuck in these bad patterns that they can't get out of. So patterns of depression where people feel worthless and then they can't get out of that, and their lives don't have meaning, and or people in drug addiction, they feel they can't get out of that. People with obsessive compulsive disorder, there's a whole lot of psychological conditions where people seem to be stuck in a pattern that they can't get out of. And it may be that just this transient disruption of the default mode network enables a reset of the brain, sort of like turning your computer on and off. That's kind of the thinking. Now it's not absolutely clear that that's true, but that's kind of the thinking for some of these things. Another set of effects that people see in animal studies and in cultured cells and in vitro studies, you can see that nerve cells change their connectivity in response to psilocybin. And that's preserved over long. It happens very fast, and it's preserved over a long time. So here's a study that just came out, last year, 2021, out of Neuron, which is a very prestigious neuroscience journal. Researchers out of Yale, which is a well-known school, although I'm not familiar with these particular researchers. Psilocybin induces rapid and persistent growth of dendritic spines in frontal cortex in vivo. So dendrites are processes on nerve cells where they receive inputs from other cells, and spines are little bumps on the dendrites where synapses are formed, where connections are made. And they administered a single dose, of psilocybin to mice, and they found a single dose of psilocybin led to 10% increases in spine size and density. Occurred quickly within 24 hours and was persistent 1 month later. So results demonstrate psilocybin evoked synaptic rewiring in the cortex is fast and enduring, potentially providing a structural trace for long-term integration of experiences and lasting beneficial actions. So it's not just made up. I mean, it looks like there's real biology underlying these changes. So the data is still early days, but it's really promising. There's tons of science going on. And so efforts to reduce legal restrictions have arisen. you have probably heard of these. In May 2019, Denver voters approved Ordinance 301, decriminalizing possession and use of psilocybin mushrooms for adults over 21. This was followed a month later by the City Council of Oakland, where the City Council unanimously voted to decriminalize entheogenic plants and fungi. Entheogenic is a word that some people use for this group of compounds rather than hallucinogenic or psychedelic. And then a number of other cities and localities acted subsequently, too many to list now. Then in 2020, Oregon voters and the general population in Oregon approved ballot measure 109, authorizing production and administration of psilocybin mushrooms and products to adults over 21 under the supervision of registered therapists. So it's not a marijuana dispensary model where you just go pick something at the store and take it home. This model requires that substances, these mushrooms, only be administered by a therapist in a setting, and you need to stay there and not drive home while the therapy is going on. But in fact, there's no diagnosis that's required, so anyone could potentially seek out this therapy. And many people have said that these are beneficial experiences in their lives, right? So it's not restricted to people with a medical diagnosis, but it is done under supervision in a careful way. So they've spent the entire last year, all of 22, writing regulations to try and enact this measure, and they've been having public comment on the regulations, and they're due to start issuing licenses next year, very soon. So this gentleman, Tom Eckert, was one of the founders. He and his wife, who has since passed on, unfortunately, were the main sponsors and initiators of this project in Oregon. And then, as you no doubt have heard, Colorado, where I live, just announced the results of the November election last month, and Proposition 122 was authorized. And this is the Colorado Natural Medicine Health Act, and again, regulated production and administration of psilocybin-containing mushrooms is authorized. So under the watch of a therapist. So these regulations have yet to be written. That will start next year. And this also allows, this decriminalizes personal use and cultivation for adults over 21. And in theory, substances other than psilocybin mushrooms, plants containing dimethyltryptamine, ibogaine, or mescaline, but not peyote. We can talk about that if anyone's interested. May also be added in subsequent years. So I've talked long enough. At least I've lectured long enough. I will end here, and then we can take questions, and thanks for your attention. So I will stop my sharing and we'll open it up for questions.
Thank you, Ken. That was awesome. Just a fabulous presentation, and we had a lot of chat going on during it. Now we have 13 questions right now in the Q&A. I don't know, do you want to scan those and answer those as you see fit?
Why don't you just throw them at me?
Sure.
You can pick and I will.
Okay. I'm gonna encourage Brooke to pick one too. I think I'll pick the first one, Brooke, if you want to get the second one ready. This is from Greg Sanchez, another Coloradoan. I think it's that Greg Sanchez anyways. Any thoughts
Hi, Greg.
about advantages or disadvantages with the use of synthetic psilocybin? He said, I know synthetic doses are easier to regulate. Do you know of other compounds in psilocybin species that might also impact beneficial effects, i.e. entourage effects?
People talk about entourage effects. So the idea that other substances may contribute and a mixture of substances may contribute. Honestly, my personal opinion is I don't think that's a big effect. In psilocybin mushrooms, there are other compounds in there. There are things that vary in the number of methyl groups that I showed a slide of. I don't really think that's a big, for many people, the fact that it's mushrooms and a natural substance will have psychological implications that they'll feel good about. But synthetic psilocybin should be effective also. And all the studies are done with synthetic psilocybin because it's easier to measure, and that's how medicine likes to work with known substances. You could, to get away from the standardization problem with the fact that you don't know in any given batch of mushrooms how much psilocybin is in there, you could potentially take a large number of dried mushrooms, powder them, put them in capsules, measure that aggregate, how much psilocybin, so you would know exactly how much is in a capsule. So it's overcomable, but some people like the thought that it's a mushroom and would rather just eat dried mushrooms. So I think there will be both kinds of things available, capsules and mushrooms. And I don't know that it's going to be the biggest problem going from a purified psilocybin to dried mushrooms. We'll see. I mean, unfortunately, we don't have data back yet from Oregon. It might have been nice to see how it works in Oregon before, for example, Colorado made its law, but we're just plunging ahead.
Okay. Brooke, you want to fire the next one?
I do. Dan Small asks, what is your position on whether hallucinations are necessary for the therapeutic effects of psilocybin?
Oh, this is a great question. There are a group of researchers who are trying to play with some of these compounds and see if they can separate therapeutic effects from hallucinogenic effects. The idea might be is that this drug produces a number of effects, and it's not necessarily the case that the hallucinatory effects are the same effects that cause the beneficial changes in depression and in neuronal connectivity. So there are a group of researchers making compounds trying to see if they can separate those. I personally think it will be unlikely, but it's just a guess. We'll see. We'll know the answer to that in the next few years, but I don't think it's going to work. I think actually the hallucinogenic effects are part of why that it works, but I don't know that.
Here's one an anonymous attendee asked, have there been any studies with phobias?
Oh, that's a great question. You should go ahead and look at the clinicaltrials.gov site, because I don't know the answer to that. I bet there's some in the works, but I don't know the answer. Clinicaltrials.gov.
Okay, this is a question. I think it's more of a topic, but John Harbour asks, because of physical effects like heart rate, exclusion criteria for clinical studies typically exclude anyone over 65, people with arrhythmia and coronary artery disease. Can you comment on the state of data for older people taking psilocybin? Do we have good data right now in light of the end-of-life studies?
Oh, that's a really good question, and I don't know the answer. We're certainly going to be seeing use in a much broader population than we have for the clinical trials now that things are getting legalized in Oregon and soon in Colorado. So we will be seeing broader use, and we'll be seeing problems, unfortunately, because the more people you give something to, more things will happen. I don't know the answer to that question. I'm hoping for the best. When people do these studies, they were bending over backwards to try and make sure they would get the best of chance of seeing an effect if there was one. So they didn't want bad things to happen to people. Any reason they could think of for excluding somebody who might have a bad effect, they wanted to, because they really want this data to show positive effects. And they really want to jump through all the hoops and do things as medically and scientifically correct as possible to get away from the sort of crazy days of Timothy Leary when everybody should take drugs. Honestly, the Good Friday experiment that I told you about, looking at religious effects, Timothy Leary said the researchers should be taking these drugs at the same time too, and everybody should be, that kind of craziness sort of ruined it for everybody. And so people are bending over backwards to try and do things the right way. But that's going to change when it opens up to a broad population. And I hope things don't go too badly.
Awesome.
Okay. Well, here's a question from Pat Mitchell out of Virginia, well known as the singing forager, who also does some nice presentations there on ovoids. And he asks, is there any current research or knowledge on psilocybin-containing mushrooms being used by ancient indigenous peoples of the East Coast U.S.?
Oh, that's a fascinating question. I unfortunately have no idea, but it's a great question. Sorry.
I have a follow-up to that, which is John Harper again. What is the significance of all the strains and species insofar as active chemicals and effect? If you can talk about that.
Oh, yeah. So if you go on the spore sites selling Psilocybe cubensis spores, there are people have collected mushrooms from all kinds of places. You can buy spores from Ecuador or, and they've also, many of them have interesting names, Golden Teacher and B+. And so they have slightly different amounts and things. Honestly, I don't think there's going to be different effects. I don't think that there are substantially different effects. There are some strains have higher levels of psilocybin and psilocin than others, but I don't think you're going to see really different effects from Ecuador versus penis envy, for example. That's a crazy named strain that people talk about that has high levels of psilocybin.
Yeah, enigma. Trent, do you have other questions? There's a lot of questions here.
There's a lot in here. I have one from Kat Graves. Her asks, cognitive neuroscientist here. I'm curious as to how brain entropy was operationalized in these studies. Thanks.
So how it was defined, I'm sure, is things just look more random. Things aren't as connected. So normally you see if this region of the brain is active, you expect maybe this other region to be active. And in the case of psilocybin, you didn't see the same patterns anymore. So, and things were more diffuse and they were, so in terms of the details of how those studies were done and how that was defined, you'll have to look up those studies because I don't have the details, but that's sort of the general idea. Honestly, the imaging studies get technical really fast in terms of blood flow and oxygen levels, and the data are extremely heavily manipulated before any of the images that you see. There's so much processing that goes on, and different labs do it slightly differently. It's not as standardized as you would like.
Okay, I have never heard of this because my experience is limited to mushrooms, but apparently there's an issue with visual snow occurring through the use of LSD. And Scott is asking, have there been any reports of visual snow among psilocybin users?
Oh, interesting question that I don't know anything about. Sorry. Yeah. I would expect similar effects. So if people are seeing that with LSD, I imagine somebody will start talking about it for psilocybin, but I don't know that. I have not heard that.
We had several people in here ask, I think I know the answer, but I'm curious too. Why was peyote excluded from the Colorado laws?
Oh, that's a really good question that I actually do know the answer to. So thanks for asking. Peyote right now is legally allowed for use by people within the Native American Church. So indigenous cultures that have a long history of use of peyote. So the American Indian community has used these agents and is licensed to use peyote. But peyote grows really slowly and only grows in a very small region in this country of Texas, and then it grows down into Mexico as well. So the demand for peyote will really, really soon outstrip availability. And if it's made available for others, it will soon be priced out of sight and become unavailable for the indigenous Native American community who've used these agents for years, if not centuries. So that's the worry. And so peyote in particular, that cactus, people are saying, let's leave this where it is. Other cacti, such as San Pedro cactus, which grow faster, it can be made available to more people. There are other sources of mescaline that could be used for others. That's the thought behind it. That's why it was excluded.
Yeah, I just want to comment that the peyote cactus is a very slow growing cactus.
Yes,
it
exactly.
takes years to become even a portion of a therapeutic dose.
Yes.
So we really need to leave that alone. It's been plowed under and abused for political reasons in our border areas and south of the border for way too long. It's really unfortunate because we're losing strains of that too. So it
takes 5 to 10 years. It's actually easy to grow, but really, really slow. So if you plant a seed, it takes between 5 and 10 years before you can harvest the cactus. And then you can cut off the top and it will regrow. But again, it takes about 8 years before it grows back to a harvestable size. So it's just not sustainable for the community at large under these conditions.
Ruthie Ristich asks, are you hearing anything about use of psilocybin for stroke survivors, neuroplasticity?
Oh, I love these questions. I wish I knew the answers to more of them.
That's okay.
I don't know. Yeah, but I love.
Okay, I got another one that may stump you while we're on them. What genre of music is administered in psilocybin studies? Is there a playlist?
Oh, there absolutely is. You can find the playlist online, and Johns Hopkins has published their playlist. If you look around enough at Roland Griffith's publications, you will be able to find it. It's very classical and lots of instruments and it's timed so that when you're peaking the dose, the music gets more intense. It's very scripted, and the classical music doesn't work well for everybody. Some people don't like it. There are definitely people who say this is not my kind of music. There's going to be a huge room for looking at potential effects of different kinds of music in the experience and different kinds of supportive therapy. It's going to be really interesting.
Hey, let me jump in there.
But everybody's been doing the same thing.
Rose just posted in the chat that I think if you scroll up in the chat, that there's a music list posted in there.
Oh, terrific.
So maybe somebody can repost that for anybody that's still looking for that. Well, maybe we can get it reposted in there. Go ahead. Go ahead, Brooke. Your turn.
I had the question and it went away. It was about oh shoot. Sorry.
Well, I'll fire one in real quick. I got
go
one
ahead,
right
go
here
ahead.
from Jesse Dubin. He I think is asking, as a Mexican doctor in Tijuana using a toad toxin to treat PTSD with positive results. Is that similar to psilocybin? And I think we have a similar question about ketamine as well. Maybe you could talk about those two drugs. And
Oh, sure. So ketamine is approved in the United States now. It's in a different class of drugs. It does cause hallucinations and dissociation, but it's not the same class. It's not 5-HT2A agonist. So it doesn't do the same things, but it does have interesting activity, and there are clinics using it now. And it's, again, a low number of dose kind of thing. The toad venom in Mexico is a derivative of DMT, and it's given by inhalation. You smoke it, and it has very rapid effects. So again, it's the half-hour kind of thing. And you can make synthetic versions of that, and people are doing that and will be testing that more. Honestly, in my opinion, I think 30 minutes is, I don't know this is just an opinion. I think 30 minutes is not going to be enough processing time to get all the effects that people are getting from psilocybin. And I think it may be that you need a few hours of this before you really get the breakdown in the default mode network to a level that has significant substantial effects. But we'll see. I mean, people are doing these experiments and will be doing more of them, and it's early days.
Okay. And Brooke, I know you're lining up for another one here. I just want to follow up. There's another question related to this. What about Amanita muscaria from an anonymous attendee? Is research being done on that as well?
There really is not. No, again, totally different class of drugs. There are no clinical trials. There's not that level of interest in that agent. There are people playing around. There are people experimenting just themselves. And I know there's interest in the community, but there's not interest in the medical community yet for that, and a very different sort of drug and drug effects than psilocybin.
I just found out yesterday that they're going to start selling an Amanita muscaria product over the counter in a CBD kratom shop in Chicago. So we'll see how that goes. This question is Andrea von Wine, and it says, does psilocybin effects change when the mushroom is cooked? Do we know percentages of psilocybin component per gram of mushroom? That's all. It's two questions, but it's all submitted as one question.
I'm sure it depends how high you cook it for how long. I know that psilocybin is stable to boiling, so you can crystallize psilocybin out of boiling water. It's not degraded by that temperature. But in terms of higher temperature, if you're cooking at higher temperature for longer times, it's not heat stable forever and under any temperature. And I don't know the particulars of how quickly you would lose it at what temperature, but I know it's stable to boiling.
We have a couple questions here related. I'm just going to read one from a queen. And that says, in regards to enhancing the sense of connectedness to nature, thoughts on conducting sessions in a lab or therapist room versus outside. And somebody else asked about how does context matter for the therapy results?
Well, anecdotally, a lot of the people who take mushrooms for whatever reason really like being outside, but none of the therapeutic models are doing that because, and for example, in Colorado, it will be specifically excluded to use the mushrooms in a public space. You have to be in an enclosed place. They just don't want people getting into trouble, and they don't want, so it's going to be regulated, but that doesn't mean that it wouldn't be good. All of the studies that I've mentioned with psilocybin, they're all done in that very early model that I showed you out of Johns Hopkins, where people are in a room that looks like somebody's living room with eye shades and music. That's all they're studying. They're not studying other ways of administering it. So that's all we know so far. All the studies are done like that. I think those variables will be significant. We know set and setting matter, but nobody has studied that at all. It's early days.
Cool. Susan Stacy asks, does psilocybin have side effects as most therapeutic substances have in modern medicine? And she lists dry mouth, headache, etc. I want to chime in that it makes me, at some point during the experience, I get very, very cold. Like hypothermic cold is the feeling, even though I'm probably not. But I would consider that a side effect. But what else is there?
More than 3/4 of people report headaches, from what I've read in some of these studies. So there's definitely side effects. And you see increased heart rate in everybody, and increased blood pressure. Is it to a level that is worrisome? It probably could be in people who already have high blood pressure. So that probably will still need to be screened for and thought about. Nausea. I just see somebody in the comments. Nausea is, again, really common, and that you see that even with purified psilocybin. So it's not just mushroom related. Some people say, well, it's other things in the mushroom. That could be the case, but you see it also with purified psilocybin. So nausea is a significant side effect. More than 1/4 of everybody. I don't know the exact numbers, but it's a lot. It's not 10%. It's more than 25% of people will experience nausea at some point. Usually early, and then it goes away, but people are different.
Okay, and we're doing good here. I propose we go for 4 more minutes till 30 minutes after the hour. That'll give us a few more questions. That's okay with you. I've got 2 related questions here. One from Larry Rappaport and one from Mark Johnson. Larry asked, why would a mushroom evolve to produce psilocybin? And I like Mark's question. He wants you to speculate on why psilocybin mushrooms evolved.
Oh, great question. You know, there's a researcher who I think just gave a NAMA talk, Bryn Dentinger at University of Utah. He's tried to look into this. People have talked about possibly an effect on insects, possibly deterring insects from eating mushrooms. So a mushroom might evolve compounds to protect itself from being devoured by another creature. It doesn't seem like the insect story is true. They actually showed a little bit of data that said that at least the kinds of mushroom flies that often consume many of the wild mushrooms that many of us forage for, they don't seem to be deterred by psilocybin. And you can find fly larvae in psilocybin mushrooms sometimes, and they will grow. Instead, Bryn Dentinger's group has speculated that it may be slugs, that slugs and snails may be deterred by it. And they have a little bit of data. He presented a talk at Telluride where he talked briefly about that. So that's where they're going. The short answer is we don't know. Why do any plants evolve substances? Why are there things like opiates, you know, and why is there cocaine? Why are any of these substances? We just speculate, but Bryn Dentinger has thought more about this than I have, and they're now looking into mollusks, into slugs and snails, as maybe that's the deterrent, because certainly slugs and snails are significant predators of mushrooms.
Cool. I want to throw this question in there, that we have a gentleman who's an ALS patient, Lou Gehrig's disease. He is interested in the possibility of using psilocybin for a spiritual experience, but are there any studies published on the use of psilocybin and ALS? that you're aware of?
Not to my knowledge, no, not that I'm aware of. I'm not, unfortunately.
I haven't heard of it either, but I hope he does it.
A trip to Oregon or in the near future, or Colorado later. Yeah, good. Best of luck.
We have a question from Daniel Smoliga asking about, is there research being conducted in creating new compounds analogous to psilocin, DMT, et cetera?
Oh my gosh, yes. There's a ton of research. There's a gold rush of companies trying to make every derivative you can think of. The guy who actually synthesized most of the psilocybin used in the studies, Roger Nichols, who's a retired chemist, but was DEA certified to make these kinds of chemicals. He has said that he really feels from what is it called? Acetylpsilocin. So if you replace the phosphate with an acetate group, that's easier to synthesize chemically, and it has really similar effects in people. But people are also playing with compounds that are more derivatized and have shorter effects. So people are looking for a 2 or 3 hour window instead of a 4 to 6 hour window. There are compounds like that have been described. Once you get into the pharmaceutical chemistry and start manipulating this, there's lots of directions you can go. Psilocybin is nice because it's a natural product that we know is very low toxicity and has a history of human use. Anything else would need a lot of human studies, first animal studies, before you can get it into humans and see how safe it is.
Melissa Klotka asks, do psilocybin mushrooms ever sedate people to the point where they feel paralyzed or unable to speak in high doses?
This is something people have talked about. There is a thing called wood lovers paralysis. There are a set of these mushrooms. I mentioned Psilocybe cyanescens, Psilocybe azurescens, some of the ones that are high potency and grow on wood chips. There is a syndrome where people have described paralysis occurring where they can't move their legs, or they're clumsy, or they really can't move it's always transient. Sometimes it's even the next day though. And there has been speculation that a compound called aruginacin is involved, but medically we know almost nothing about this. This is just anecdotal reports from people who've eaten mushrooms. That has never been described from Psilocybe cubensis. The state of Oregon limited its legalization specifically to the species Psilocybe cubensis, partly for that reason. That's where we have the most experience. Colorado has not done that. So those rules have yet to be written, but it certainly was not in the initial language. So yeah, it's potentially worrisome, and we don't know enough about it yet. But it is transient. Okay. It occurs. But
I'm going to shoot you the last question. It's kind of a broad one here that's been coming in on the chat a few times. But I'm going to precede that by reminding everybody that this presentation will be posted up on our website on the webinar page. I think it's under the events category. In the next couple of days, give me a couple of days to get it ready. We'll put it up and you can watch it there at your leisure. So the question that's coming in on the chat a few times, people are asking about microdosing, about any data that you have on it that you could share. I know you touched on it a little bit, but if you could just kind of close up by maybe telling us a little bit about microdosing.
Sure. People are very interested in microdosing. So microdosing, as you know, probably is much smaller doses that don't cause active hallucinations, sometimes subperceptual or just slightly stimulating. So on the order of a tenth the size, or sometimes a fifth, but a low dose. The studies that have been published don't show difference between placebo. But people's anecdotal responses do show promise. So a lot of people feel that this is really helpful for them. And so, you know, if it helps people, that's great, but we don't have medical data to back it up yet. You tend to need, for small effects and subtle changes, you tend to need much bigger groups. It's harder to actually do those studies. It's expensive to do medical studies. I don't know that we're going to have good data right away, but I know a lot of people are playing around on their own, and some of those people feel it's very helpful for them. But I can't say medically we have good data that yes, this is useful.
Okay, well, thank you very much.
Yes.
We all learned so much over the last 90 minutes from you.
It's been my pleasure. Thanks for having me.
Okay. Goodbye, everybody.
Thank you, everybody.
See you at the next one.
Bye-bye.